Schizophrenia is a common, severe and disabling chronic mental health disorder that represents a significant social and healthcare burden. People with schizophrenia have a life expectancy that is 15 to 20 years shorter than those without the condition. Coronary heart disease is a leading cause of death in this population, with up to 75% of patients dying from this condition. In addition, at least 1 in 4 patients with schizophrenia have metabolic syndrome, 1 in 2 is overweight, 1 in 5 has significant hyperglycemia, and at least 2 in 5 have lipid abnormalities. People with schizophrenia tend to look after themselves less well, are more likely to smoke, and less likely to eat healthy foods and take regular exercise. Antipsychotic medication can contribute to weight gain and increase the risk of cardiovascular disease and diabetes. These physical health problems contribute to premature death. Furthermore, an estimated 1 in 20 people with diagnosis of schizophrenia will end their own lives. Professor David Taylor, Director of Pharmacy and Pathology at the Maudsley Hospital, explains.
So people with schizophrenia, estimates vary, but they die on average 20 years earlier than one might expect for somebody without the condition. The main cause of death is cardiovascular, that is they're dying of myocardial infarctions, strokes, heart failure, that kind of thing. And you can detect quite early on, even at diagnosis, that people's bodies are primed for the kind of metabolic disturbance which will ultimately lead to cardiovascular disease. So for example, they tend to have high levels of cortisol. People that at first diagnosis also tend to have higher levels of cholesterol, high blood pressure, that kind of thing. At the very least, a new treatment for schizophrenia should not add to the metabolic effects that are already there. So it should be what we call in pharmacology metabolically neutral. It shouldn't change cholesterol, it shouldn't change triglycerides, it shouldn't change glucose tolerance, and it shouldn't change weight. So any new drug really that's going to come into the field has to have those properties. I suspect otherwise it wouldn't be accepted.
LATUDA, or lurasidone, is an atypical antipsychotic agent that became available in the UK in 2014 and is licensed in the EU and the United States for the treatment of schizophrenia in adults aged 18 years or older. It has been licensed in the US since 2010, and to date it is estimated that approximately 1 million patients worldwide have used LATUDA. LATUDA has been designed to be different. The molecular structure of LATUDA allows hydrogen bonding with dopamine D2 receptors, as well as affinity binding with serotonin type 2A and serotonin type 7 receptors, and prevents steric binding to muscarinic M1 and histamine H1 receptors. Dr. Andrei Pikolov, Executive Medical Director of Sanovian, explains the background to the development of LATUDA.
While we all understand that the treatment decision is a very intimate process and made between the patient and their physician or healthcare provider, there is no medication which fits all sizes, which we understand this is a very complicated disorder. With LATUDA, we have been able to demonstrate through the series of well-designed and well-conducted clinical trials that this is efficacious medication. It works for patients with schizophrenia. It helps them to see the improvement and experience the improvement in their symptoms.
Similar to most second-generation antipsychotics, LATUDA is a high-affinity antagonist of the central dopamine type 2 and serotonin type 2A receptors. The antipsychotic activity of LATUDA is thought to be primarily mediated through binding to these receptors. LATUDA is also an antagonist with a very strong binding affinity of the serotonin type 7 receptor and a partial agonist at serotonin type 1A receptors. These binding properties are also thought to be involved in mediating the antipsychotic effects of LATUDA, and in preclinical animal models have been shown to be related to effects on mood and cognition. In addition, LATUDA has very low affinity for serotonin type 2C receptors and virtually no affinity for histamine H1 receptors, both of which are thought to be associated with the drug's lower propensity for weight gain. It is important to note, however, that the correlation between the various receptor binding affinities of LATUDA and clinical outcomes remains to be established. LATUDA is different from other second-generation antipsychotics. All these medications differ in their receptor binding profiles and differ in their clinical profile. Blockade of H1 receptors has been associated with weight gain, diabetes and sedation. Blockade of M1 receptors has been associated with blurred vision, dry mouth, constipation and cognitive dysfunction. The influence of the receptor binding profile of LATUDA on the manifestation of adverse events has not been established. LATUDA has been shown to rapidly control schizophrenia symptoms. In the randomized double-blind phase of the pivotal Phase 3 PEARL-2 study, after 6 weeks of treatment, patients receiving LATUDA 37 mg or 111 mg once daily showed a significantly greater improvement in the primary study endpoint, PANSS total score, compared with placebo. Symptom improvement versus placebo was observed as early as week 1. Similarly, patients receiving LATUDA 37 mg or 111 mg once daily showed significantly greater improvements versus placebo in the CGI-S score after 6 weeks. Importantly, a post-hoc analysis of the PEARL-2 study demonstrated that there was no significant difference between LATUDA and olanzapine in terms of efficacy as measured using PANSS total score and CGI-S score at 6 weeks. Furthermore, in the randomized double-blind phase of the PEARL-3 study, during which patients received a fixed dose of LATUDA, 74 mg or 148 mg once daily, QUETIAPINE XR 600 mg once daily, or placebo once daily for 6 weeks, LATUDA demonstrated significantly greater improvement than placebo in PANSS total score. LATUDA demonstrated significant symptom improvements versus placebo as early as day 4. The efficacy of LATUDA has been shown to be maintained over the long term in several clinical trials. For example, in a subgroup analysis of a double-blind placebo-controlled study, subjects switched from olanzapine to LATUDA in the open-label extension phase, maintained efficacy improvements through 8 months as measured by PANSS total score. Compared to QUETIAPINE XR, LATUDA was non-inferior in time to relapse and demonstrated significantly lower rates of hospitalization, 57% risk reduction over 12 months. Cognitive performance was also assessed during this study using the Cogstate computerized cognitive test battery. Cognitive performance was significantly superior in patients who received LATUDA throughout the study compared with those who received QUETIAPINE XR. Importantly, cognitive performance was shown to be significantly correlated with functional capacity as assessed using the UPSA-B measure. 33% of people living with schizophrenia are obese compared with 21% of people without the illness. Although clinically effective, treatment with some second-generation antipsychotic drugs can worsen components of metabolic syndrome, such as weight gain, the development of hypertension, and dysregulation of both glucose and lipid metabolism. Weight gain with some drugs can be rapid and substantial. Weight gains of 5 to 6 kilograms within 2 months of starting an antipsychotic are not uncommon. In fact, the summary of product characteristics of the commonly used atypical antipsychotic, olanzapine, states that after 12 months of treatment with this drug, 64% of patients will have gained more than 7% of their body weight. In addition to the detrimental physical health consequences of weight gain, the distress experienced by patients as a result of weight gain can lead to poor adherence to treatment and high relapse rates. In clinical studies, whilst weight gain was observed in some patients, LATUDA has been shown to have a low propensity for weight gain, as well as minimal effects on glucose metabolism, cholesterol and triglycerides. In a pooled analysis of data from 7 6-week double-blind placebo-controlled studies, treatment with LATUDA was associated with minimal changes in mean weight. Although mean weight gain compared to placebo was negligible, some patients may gain weight, and weight gain is listed as a common side effect in LATUDA's summary of product characteristics. In short term, 6-week studies, 4.8% of patients on LATUDA gained weight. Importantly, LATUDA has also been shown to have a negligible effect on weight and other metabolic parameters over the longer term. In a 12-month safety study, patients treated with LATUDA experienced a mean decrease in weight and body mass index, while those treated with risperidone experienced a mean increase in both parameters. Some patients on LATUDA did, however, gain weight in the long term, but a similar number of patients lost weight. For the population as a whole, LATUDA seems to be weight neutral, or may in fact lead to a reduction in average weight. In patients who have gained weight on other antipsychotics, positive effects can be achieved by switching to LATUDA. In one study, it was shown that on average, patients gained 4.6 kilograms after 6 weeks of treatment with olanzapine, then experienced an average weight reduction of 1.9 kilograms over a 28-week period when switched to LATUDA. People who have a diagnosis of schizophrenia are more likely to develop physical health problems, including weight gain, high blood pressure, heart disease, and diabetes. In a pooled data analysis of double-blind short-term studies, treatment with LATUDA was associated with negligible changes in mean glucose, cholesterol, and triglyceride levels, as well as negligible changes in cardiometabolic parameters. No adverse events that could be linked to QT prolongation in the LATUDA short-term or long-term Phase 2 and 3 studies were observed. Caution should be exercised when LATUDA is prescribed in patients with known cardiovascular disease or family history of QT prolongation, hypokalemia, and in concomitant use with other medicinal products thought to prolong the QT interval. In the same pooled analysis of double-blind short-term studies, treatment with LATUDA was associated with minimal changes in prolactin levels. In fact, fewer than 1% of patients were reported as having hyperprolactinemia as an adverse event whilst on LATUDA. Increases of between 160 and 600 picomoles per litre in prolactin levels were observed with the first-generation antipsychotic haloperidol and with some second-generation antipsychotics such as olanzapine and risperidone. Hyperprolactinemia has short and long-term consequences that can seriously affect quality of life. Menstrual disturbances, breast secretions known as galactorrhea, sexual dysfunction, benign enlargement of breast tissue in males known as gynecomastia, infertility, and breast cancer. It is believed that hyperprolactinemia may be associated with a decreased bone mineral density, which could result in osteoporosis. In order to assess the safety and tolerability of LATUDA, data were pooled from 7 short-term, double-blind, placebo-controlled fixed-dose studies, in which patients received either LATUDA at a dose ranging from 18.5 to 148 milligrams once daily or placebo. The analysis included data from over 2,500 patients. The overall rate of discontinuation due to adverse events was 9.5% for LATUDA, which was similar to the rate observed with placebo, which was 9.3%. Treatment-emergent adverse events that were reported by at least 5% of patients treated with LATUDA were nausea, somnolence, akathisia, and extrapyramidal symptoms. Overall, 1.4% of patients taking LATUDA discontinued due to akathisia versus 0% with placebo. The impact of akathisia was decreased when LATUDA was administered after the evening meal. Please refer to the summary of product characteristics for a full list of side effects. LATUDA is indicated for the treatment of schizophrenia in adults aged 18 years and over. The efficacy and safety of LATUDA have been established in numerous clinical trials over the short and long term, as we have discussed earlier. In its evidence summary, New Medicine, NICE concludes that LATUDA is superior to placebo and non-inferior to quetiapine prolonged release for preventing relapse in adults with schizophrenia. NICE also cites the EMA's European Public Assessment Report for LATUDA, which states that LATUDA's safety data indicate a relatively favourable metabolic profile. In 2014, LATUDA was also accepted by the Scottish Medicines Consortium for the treatment of schizophrenia as an alternative treatment option in patients in whom it is important to avoid weight gain and metabolic adverse effects. Similarly, LATUDA was accepted by the All Wales Medicine Strategy Group in 2015 as an option for use within NHS Wales for the treatment of schizophrenia in adults aged 18 years and over. The recommended starting dose for LATUDA is 37 milligrams once daily, taken with a meal. No initial dose titration is required. The effective dose range of LATUDA is 37 to 148 milligrams once daily. Dose increases should be based on clinician judgment and clinical response. In a clinical trial, Patients who had not responded to 74 milligrams at 2 weeks and had their dose doubled to 148 milligrams showed more improvement than those who continued on the same dose. There was a minimal increase in adverse events associated with this dose increase. Dosing adjustments for special populations are recommended, as outlined in the summary of product characteristics. Patients taking LATUDA should be advised to swallow their tablets whole. LATUDA must always be taken with food. In the clinical trials, patients were dosed within 30 minutes of an evening meal. Taking LATUDA after an evening meal every day may help patients establish a routine to help aid compliance. Switching to LATUDA from other atypical antipsychotics can be simple and maintain symptom control. This is Professor Stephen Stahl's switching guidance from his book, The Prescriber's Guide, which may assist the clinical decision-making process when choosing the most appropriate switch strategy. Professor Stahl suggests that for antipsychotics with a short half-life, such as risperidone and quetiapine, a cross-titration approach should be considered. This means that the previous antipsychotic should be down-titrated whilst LATUDA is initiated at 37 milligrams. For antipsychotics with a long half-life, such as aripiprazole, Professor Stahl suggests there may be no need for this cross-titration approach. The previous antipsychotic could be stopped and LATUDA 37 milligrams started straight away. Switching strategies are a matter for individual clinical judgment, and the prescribing information for the treatment that is being discontinued should be followed. Professor Stahl, adjunct professor of psychiatry in the School of Medicine at the University of California in San Diego, shares his thoughts on switching to LATUDA from other antipsychotics.
There are data that do show that LATUDA maintains efficacy after switching from other antipsychotics. There's a formal switch study which was done, and of course when you go into trials from other medications, almost all patients have been treated previously because trials are not usually a first break patients. So there's quite a bit of evidence that if a patient takes LATUDA after switching to from another antipsychotic, that it will be effective in maintenance. The way I would advise clinicians to switch to LATUDA from other antipsychotics is generally by cross-taper, which means stopping the first medication slowly and starting the second one, in this case LATUDA, slowly. Slowly means taking maybe half the first medication away while starting at the 37 milligram dose of LATUDA, and then after a week or two, stopping the first medication entirely and then going up to 74 milligrams if the patient seems to need that.
While there are several options available on the market today, and patients benefit from currently available treatments, we hope that LATUDA will be an option for those who may need an additional choice for the management of this devastating disease, especially in those cases when undesirable metabolic complications related to the weight gain, diabetes, etc., may preclude them from using other medications.